Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Michell Ruiz from Mexico. Dr. Ruiz was appointed as an attending physician at the National Institute of Rehabilitation in Mexico after finishing a sports medicine fellowship at the Plano Orthopedic and Sports Medicine Center in the US. He's a founding partner and attending physician at the Traumatología Deportiva de Mexico, where he also serves as the co-director of the Sports Medicine and Shoulder and Elbow Surgery Fellowship. He serves as associate editor for the Acta Orthopedica Mexicana and is an editor and reviewer for several orthopedic journals. He has also been the president of the Mexican Shoulder and Elbow Society in the past. If you've noticed, Dr. Ruiz has delivered several lectures on our channel, and today is my great honor to bring back Dr. Michell Ruiz for this wonderful live program. Over to you, Michell.
Thank you very much. Thank you very much again. This is a huge honor to have another participation in your channel. So I was invited to talk about the current concepts in posterolateral rotatory instability of the elbow. It's a topic that I love, and unfortunately, it is also a topic that there is not much awareness in the orthopedic community. So hopefully, we can give some light on this topic. So as you can see here, the history goes back almost 60 years ago. The first description of this instability, because at that time in 1966, when Osborne and Cotterill describe it, they didn't describe it as posterolateral rotatory instability. They only described it as a residual instability after an elbow dislocation. It was until 1991 when Dr. Driscoll in Mayo Clinic described this instability as a PLRI. And he was also the first one to describe which was the pathomechanics of this instability. We can say that the PLRI is the most frequently recognized instability of the elbow, although there is some debate on which are the structures that really cause it, as we are going to see in a bit. It is like widely recognized that the lateral ulnar collateral ligament is the most important structure of the posterolateral region of the elbow, preventing the varus momentum and also the external rotation of the forearm. But as we are going to see, there are also other structures that may be playing some important role in the pathomechanics of this entity. Of course, we have to talk about the etiology. The most frequent one is acute, the acute cause, and it is almost always secondary to a posterolateral dislocation of the elbow. Sorry. As we know, this is the most frequent variant of elbow dislocation, and it almost always involves the posterolateral ligamentous structures. Of course, there is also a chronic, various causes of chronic insufficiency of the posterolateral structures, and we can name some of them. The first one will be the inadequate healing of the LUCL. And this is mainly because it was such an important mechanism of dislocation that there was not enough tissue to heal on the lateral side for the LUCL to continue to play its role. The second one is patients with pediatric sequels of some supracondylar fractures and having secondary cubitus varus. In these patients, they may have some PLRI secondary to insufficiency of the ligamentous structures. A very frequent cause in my practice is also a iatrogenic cause. And this is because some patients may have some pain secondary to lateral tendinopathy, and they have multiple steroid injections at this site. And this will cause a problem at the insertion point of the LUCL and other structures of the posterolateral complex, and this will also cause an insufficiency of the LUCL. And finally, it is not that frequent, but we also have to suspect it in patients with a generalized ligament laxity. As we know, the elbow is the most congruent joint in the body, as we can see here. And we are not going to talk about instability secondary to intraarticular fractures. We are only going to focus in the insufficiency of the ligamentous structures. But it's important to be aware that the bone has a very important stability due to its bone structures on its own. And this is very important to recognize. The LUCL does not work on its own. There are at least two other ligaments that work in coordination to stabilize the elbow with invarus and also with the rotation of the forearm. This would be the radial collateral ligament and also the annular ligament. These three ligaments will compose the posterolateral ligamentous structures. But, and this is important, a new player has come into the scene. And this is the posterolateral ligament. Again, since 1966, Osborne and Cotterill described these capsular or ligamentous structures to be important in preventing a redislocation or in having residual instability after a dislocation. But for some reason, it hasn't been recognized as an important structure until very recently when Dr. Adam Watts and his group have described it again as a very important structure, also preventing the instability, this PLRI. It is not until this year that Dr. Watts and his group have reported this paper with this title, The Posterolateral Ligament of the Elbow, the Anatomy and Clinical Prevalence at the JSES. And they are describing it first in a cadaveric dissections. It is a very constant structure, and it's very important for preventing redislocation or instability, specifically with supination of the forearm. And they also recognize in their discussion that this structure was previously described first in 2018 by Edwards, in which they described that this ligament or capsular structure, if it was not sufficient, there was an increased translation of the radial head to the posterior with regard to the forearm at 30 to 60 degrees of flexion. And there was also another report in 2022 by Lowe, in which they described if there was an insufficiency of this structure, there was increased supination over the trochlea, as we're going to see a little bit later. But what I want to state very clear is that the posterolateral ligament or capsule, there is no consensus about the nomenclature. It is very important as a fourth element of the posterolateral ligamentous complex. We have to recognize that there are also some other stabilizers of the elbow. As we have already described, the static ones are the bony structures, in this case, the ulnohumeral joint, and the medial and posterolateral ligament complexes. There are also secondary stabilizers, as the radial head, the muscle masses of the flexopronator and extensosupinator masses, and also the joint capsule. And also some dynamic stabilizers, in which we will include here the anconeus, the brachialis, and the triceps. But in case of PLRI, what is the proposed mechanism of injury? As we have stated before, the most frequent cause of this instability is a elbow dislocation. And as we already know, the most frequent variant of elbow dislocation is the posterolateral variant. This is the most widely accepted mechanism, although it has been disputed that it may not be the only mechanism of injury with posterolateral elbow dislocations. But the Mayo Clinic has been very clear in describing it. First, there is a disruption of the lateral ligamentous structures. Then it comes through the anterior part of the joint, disrupting the capsule. And then finally, the MCL will work as a hinge in which the forearm will rotate around the humerus. And this will be the most frequently proposed mechanism for posterolateral dislocations. And once there is a reduction of a posterolateral dislocation, we almost always have X-rays just to have a control. And this has been described some years ago, almost 20 years ago, as a drop sign. This sign is found in the lateral view, post-reduction X-ray views, and it is described as a widening of the ulnohumeral space more than 4 millimeters. If you find in a post-reduction X-ray this drop sign, you have to suspect with a very high degree of index of suspicion that there may be some disruption of the posterolateral ligamentous complex that may cause a residual instability. So it is very important to make these measurements in the post-reduction X-rays. But in cases that you already have a patient with a suspicion of having a PLRI, I think the most important study that you can have, specifically these imaging studies, is the MRI. First, you have to recognize which will be the normal structures. And as you can see here in figure A, the black arrow is pointing out to the humeral origin of the LUCL. And in the coronal view, you almost always see this traversing direction and orientation of the LUCL, starting from its humeral origin and then inserting into the proximal ulna. So this is very important to recognize in normal MRI images, specifically in coronal views. But as we are going to see, these are not the only images that we have to take care of. This is a patient of mine. This is the youngest patient that I have taken care of, due to a PLRI. And as you can see in the image of the left, there is a widening of the radiocapitellar space. You can see there is a clear asymmetry. So in cases of PLRI, almost always you're going to find this asymmetry. And also you're going to find here that there is a disinsertion, or at least an insufficient insertion of the LUCL in its humeral origin. It is very infrequent to have a disinsertion of the LUCL at the ulnar insertion point. It is not completely improbable, but it is not infrequent. But it is quite infrequent. And as you can see here, there is a gap of the radiocapitellar joint that is a little bit larger than 3 millimeters, and you have to be very aware of this joint widening. Of course, also in the axial views, as I'm going to point out here, there is an absence of the LUCL humeral insertion. There is fluid here. This is a T2 weighted imaging. So there is fluid here, meaning that there is no humeral origin of the LUCL, but also it is important to note that there is some incongruency of the olecranon into the trochlea. And finally, you also have to take care of the sagittal views. this is a different patient, and this patient taught me a lot because I asked for an MRI, having a high index of suspicion of a PLRI, and when he was taking his MRI imaging, the radiologist placed him in a supination of the forearm, and as you can see on the image on the left, there is a clear subluxation of the radial head posterior with respect to the capitellum. And it was just unbearable. The patient was not able to finish the study because after 10 minutes of being inside the tunnel, he was very painful, and the study has to be suspended. And then I asked him, I think the cause of the pain during the study was due to the forearm position. So I talked to the radiologist and agree and also, of course, the patient had to agree to take it again, but now with pronation of the forearm. And as you can see, this very slight but important modification of the forearm at the time of the MRI imaging was enough to see that the radial head will, I don't know if it reduced, but be in a much better place than it was before. And as you can see, there is a very important presence of fluid at the posterolateral gutter of the elbow. This is clearly a PLRI, but this is very important to notice, because if you have patients with PLRI and you're going to ask for an MRI imaging, probably you have to talk to the radiologist and try to see if it's possible to have the study with a forearm in pronation. So it is not that uncomfortable during the study. There is also, and we know, a very specific diagnostic clinical test that we can do at the office, or even at the OOR. The most important or the most frequent clinical maneuver is a pivot shift. The pivot shift in a patient that is not under anesthesia or under a regional block is very difficult to do because it's very painful, it's very uncomfortable. So probably if you're going to do this in the office setting, you're only going to have this apprehension, and you're not going to see the pivot shift at the office setting. A second test that I almost always do is a posterolateral drawer, and this highlights the importance of the posterolateral ligament, because as we already said, if there is an insufficiency of the posterolateral ligament, there is going to be a very important drawer of the elbow at 40 degrees of flexion. As I mentioned before, the posterolateral ligament it comes to work with a flexion of 30 to 60 degrees. So 40 degrees of flexion will be like the average range of motion that you will place the elbow when doing this maneuver. And you, like you do with a knee, you almost do a posterior translation of the forearm with regard to the humerus. And the last one is a chair push-up test that is somewhat useful also in the office setting. The only thing is that you need a chair with armrests, so you can place the patient sitting in the chair. Then you ask to place the patient with his forearms in a supination, trying to hold the armrest, and then asking him to lift his body weight with his arms, with his forearm in supination, and they will feel pain and some apprehension at the posterolateral region of the elbow. If you place your thumb just behind the radial head and trying to keep the radial head in its position while the patient is trying to lift from the chair, almost always the pain is gone, and this apprehension feeling is almost always gone too. And then this way you can confirm that there is a PLRI. But once we are in the OR trying to take care of this pathology, you can repeat these testings, and this is the elbow pivot shift. To do the maneuver in an adequate manner, you have to pay, well, first of all, the patient is under regional block. that is why you're going to see that the patient is wakened, but he's not placing any resistance. You have to place your forearm in full supination, and you're going to apply some valgus force going from 90 degrees of flexion and then going all the way through complete extension of the forearm. Here my thumb is trying to explain which are the structures. As you can see, that the patient is under regional block, he's wakened. And then you're going to see, once we go from full extension, that dimple. And that is showing us that there is a clear posterolateral dislocation of the radial head with regard to the capitellum, to the distal humerus. And this will confirm the PLRI, and this is how a pivot shift is done. We also have a posterior drawer test. As you can see, there is some degree of flexion of the elbow. And with one hand, I'm stabilizing the humerus, and with my other hand, I'm going to place a posterior force of the forearm with respect to the humerus. And as you can see here, it's very clear, a positive drawer test. And this will also highlight to me the incompetence of the posterolateral ligament, not only the LUCL, but if I find a posterior drawer and a pivot shift, then I will go directly to try to include these two structures into my repair or reconstruction, both the LUCL and the posterolateral ligament. And finally, if you are in the OR and you have a C-arm with you, you can also place some valgus force to the elbow, and you can also see the widening of the radiocapillary space. So that the imaging studies, the clinical testing will give you a very high suspicion index of what is going on with the elbow, and that is going to guide on how are you going to address all these injuries. And finally, I will have to say that also the arthroscopy has a very important role in the diagnosis and recently also the treatment of this entity. In patients that have PLRI, you can place your scope. I do it through the soft spot portal, but you can also place it in the posterolateral portal, I'm sorry, and then guide your camera and see if there is something in the posterolateral compartment that will make you suspect a PLRI. In this case, I'm seeing here, on the bottom, there is a radial head. On the top, there is a capitellum seen from posterior. And you can see here the disinsertion of the LUCL, but also you can see also the widening of the posterolateral gutter. So the arthroscopy definitely has a very important role in the diagnosis of the PLRI too. And having this view, as we are going to see in a very few moments, having this view can help you place your reconstruction, or trying to see where is going to be the site of insertion of your graft if you're going to do the treatment with an arthroscopic assistance. And also, you can place your scope in the anterior compartment of the elbow, and you can have very significant views of what is going on there. I'm placing my scope in the anteromedial portal. This is the trochlea. This is the coronoid, and as you can see, there is a clear subluxation of the coronoid with respect to the trochlea. And in the radial head, there is chondromalacia that is very frequent in cases of PLRI. And while I rotate my forearm, you can see that with pronation, there is a repositioning of the radial head with regard to the capitellum. With supination, there is a subluxation of the radial head. And also you can see that there is an important widening of the anterolateral gutter of the elbow. So definitely, as you can see here, the arthroscopy has a very important role in the diagnosis and I think also the treatment of this pathology. So what about the treatment? So we can talk about 4 different modalities: the conservative, the primary repair, reconstruction, and placation. So the conservative, I think it's the results are very unpredictable and they are also suboptimal. So I don't think conservative treatment in a scenario of a already established PLRI is going to have any important role. So we're going to focus in the surgical treatment of and its varieties. So first, we have the primary repair. The primary repair, I think it has a role in an acute setting, probably during the first 3 weeks after an elbow dislocation. Reinforcement, in cases you're going to do some kind of primary repair during an acute setting, but you're suspecting that the tissue at the humeral origin is not going to be of very good quality, and you want to reinforce it with some kind of synthetic ligament. And we're also going to talk about, in a chronic setting, about the LUCL reconstruction. And finally, there is an option that is a ligament plication. I think this ligament plication, whether you do it open arthroscopic, is in cases that you're suspecting that the posterolateral ligament is the main structure that is explaining this PLRI, and there may be some role of doing application of this ligament. So what about primary direct repair? Unfortunately, there are very few reports, and the reports that already exist are very small. The series are very small, and they are like not very large enough to conclude effectively. But I have to say that the reports that already exist report good to excellent results. It is very cost effective, especially in patients that already had an elbow dislocation, that you are suspecting insufficiency because you have a drop sign in the post-reduction x-rays, and you want to do a direct repair of the LUCL or even the posterolateral ligament. I think you can do a direct repair with a very predictable good result. You can do it in a minimally invasive way. One huge advantage is that it has a very rapid recovery. The only problem in cases that you're going to do a direct repair is that it requires an implant. As you can see, as we're going to explain a little bit later, the reconstruction with grafts can be done with bone tunnels, but in cases of primary repair, it's very difficult to use bone tunnels, and you almost always have to need an implant, in most cases a suture anchor. The only key point that you have to keep in mind is you have to be very, very clear about where is your center of rotation of the capitellum on the lateral side. And it has to be done in an acute setting. I have, in some cases, I have wanted to push the limits a little bit too far and try to do direct repair in chronic cases. And although in some cases it has been possible, the results are not the best. And I have had the need to do some revisions. So if you want to prevent a problem or a complication of doing a direct repair, especially if you're going to do this in a subacute setting, is to use a reinforcement. And this technique is very useful in subacute settings. I would say that probably in patients that have a history of a dislocation that is longer than 3 weeks, but probably no more than 12 weeks. if you're in this range, probably a reinforcement added to a primary repair is going to work. The technique is very similar to using doing a reconstruction with an autograft. It is cost effective, and I place a question mark here because for doing a reinforcement, you need at least 2 implants, one on the humeral side and another one on the ulnar side. Unfortunately, there are no clinical series of reinforcement. There is only this paper with very important authors with huge names, as you can see there, but it was only a bench testing. It is important to note that this technique is a little bit unforgiving in the sense that you have to be very precise in your implant positioning, because otherwise the implants are not going to be in an isometric positioning. I'm sorry, and the ligament may rub against the radial head, and you can have a significant radial head arthritis. I have not had the presence of radial head arthritis secondary to LUCL reinforcement, but I take a lot of time just to see that my positioning, that my implant positioning is in an isometric origin and insertion point, so I am going to prevent any complications. And finally, it's at least in my hands, it's somewhat difficult to calculate which is the tension that you have to leave this reinforcement, this synthetic reinforcement. I have done some, and as I told you before, you have to be very precise in calculating where is the supinator crest on the ulnar side, and also where is the center of rotation at the humeral side. And as you can see here, it's somewhat difficult to know how tense you're going to leave that synthetic ligament. So in some cases, I just place a Kelly clamp just below the ligament while trying to position the humeral implant. I almost always place the ulnar implant first, and then I place the ulnar implant at last. But as I told you before, it's not that easy to have a calculation of the tension. And this is the most frequently described technique, the LUCL reconstruction. Unfortunately, the series that are already there are not large enough to have significant conclusions. You can use autograft and allograft, and there not seems to be significant differences. This is the most frequently described technique in the literature, but unfortunately, the reports are very heterogeneous in how they report the technique or the outcome measures. It's very inconsistent, all the series on the fixation methods. Also very inconsistent on the different outcomes or of measures that the authors use for that particular study. And all of this makes that it's very difficult to conclude a superiority or even non-inferiority of one technique over the other. So I have to say that this is the most widely accepted technique, but there is like no enough information to mention which is the best one. As I showed before, it's very similar doing an LUCL reinforcement and a reconstruction. I do it with a coker approach. I have to identify the supinator crest in the ulna, and then place my insertion, my distal insertion point there. Also, I identify my center of rotation on the humeral side. I use interference screws both on the humeral and ulnar side. This is one of the first techniques I was using. I'm not using these implants anymore. I'm just using just conventional biocomposite interference screws. And what does the literature report? The literature reports that the most frequently technique that has been reported is a docking procedure or a modification of it. The most frequently reported graft is an autograft using the palmaris longus or a triceps slip. And it is not that uncommon to have failures. They have been described to be present up to 15%. And there are very few descriptions with autograft. And which are the current trends? The current trends with regard to treatment is using a scope. As you can see here, these are only 4 technical notes that have been reported in the Arthroscopy Techniques journal in the last 4 years. And as you can see, most of them use the scope as an assistance for graft reconstruction. I think it is a promising field, but unfortunately, you have to have a very substantial learning curve of elbow arthroscopy before taking the leap of doing this. And there are also a couple of papers that describe the plication, the arthroscopic plication of the PLL. I think it is also a promising technique, but you have to be very sure that the humeral origin or ulnar origin is are there. Because if you have a disinsertion of any of those sites, you're only going to imbricate a patulous ligament that is not going to have a good function. My preferred treatment is primary repair. I try to do this in an acute setting. And I almost always try to include the PLL in my repair. I almost always use a all-suture anchor device at the central rotation at the humeral site. I'm doing this in an open fashion, but I'm trying to shift to do it arthroscopically. In cases of chronic insufficiencies, I use autograft. And interestingly enough, I use the gracilis tendon as an autograft. And as I told you before, in those cases, I use interference by a composite screw for fixation. This is a paper that we presented some months ago. We submitted to Arthroscopy Techniques. And in this case, we are presenting our technique trying to include the PLL. So as you can see, this patient is going to present a very significant posterior drawer test and also pivot shift. So this is what you're going to find in a patient with significant PLRI that also is including the posterolateral ligament or capsule. And one of the things that I'm still doing this technique in an open fashion is that, as you are going to see, I am very careful about doing a very thorough dissection of the PLL from the anconeus. So I can repair it or plicate it and reinsert it with great care at the humeral site. As I told you before, I almost always do a cohort approach between the anconeus and the extensor carpi ulnaris. Once I identify this cohort interval, I am, as you can see here, I'm very careful about dissecting the anconeus from the PLL. And as you can see, that is a PLL, that patulous ligament that is like bulging from the joint. In this particular case, the patient had an avulsion, a very small avulsion of the epicondyle, and I'm going to resect a loose body. You have to be very careful to see where is the center of rotation at the lateral side. And this is the all suture anchor device that I almost always use is 1.8, and it's very bone preserving, and that is one of the reasons I like it a lot. And then I begin including my LUCL and PLL into my reconstruction. And I'm going to reinsert it and at the same time placate both structures, so I can have a stable joint after doing my repair. I'm almost always preserving my anconeus. It's as I told you before, it's a very important dynamic stabilizer of the elbow. So once I do my ligamentous repair, I'm going to do my interval repair, and that way I'm going to have once again full function of my static and dynamic stabilizers. So my final thoughts with regard to the PLRI is that there are many promising emerging techniques, but unfortunately, we still have significant research gaps. Hopefully, there will be increasing awareness about the pathology, and we're looking forward to some patient significant improvements. Gracias. Thank you very much.
Thank you, Michelle, for this spectacular presentation. Michelle, you can stop sharing. Thank you, Michelle, once again for this spectacular presentation.
Thank you.
Let's have a short Q&A.
Yes.
Michelle, the case that you showed was an acute one, right? The last one you said.
It was no, it was a subacute.
So what was the duration? When did you actually intervene?
Well, the patient came to me probably 4 weeks after having a dislocation. The dislocation was treated by someone else, but when he went back to swimming, when he tried to extend his elbow fully, he presented this apprehension feeling. So when I did the MRI, it was very clear that this was, we found the widening of the radiocapitular joint. There were some signs of disinsertion of the LUCL and also the PLL from the humeral side. And we decided to go to the surgical treatment. At first, I wanted well, I proposed the patient to do a reinforcement, but the patient was very young. It was 12 years old. So I think that helped in having very robust tissue that was a very good quality and was enough to do a primary repair. But that is not the case with adult patients.
And how early do you think we should go in? Because you should allow a natural process for healing, right?
Yes,
so how
definitely.
early do you think should we intervene in case you're doing?
Yes, I think it's a very good question, because not too early, not too late. So probably around 6 to 8 weeks after having a dislocation, it's a very good time period to see if there is a residual insufficiency.
And Michelle, when you do the clinical examination of these patients, see, when we talk about in the knee, when we discuss, we say the pivot shift is generally difficult to do in an awake patient, and you get a good one under anesthesia.
Yes.
What about the elbow? Are you able to elicit a subluxation in an awake patient, or you just rely on the apprehension alone?
No, it's just almost the same as in the knee. In the office setting, you're only going to have this apprehension. It's very difficult because it's very painful. It's very uncomfortable for the patient. So you're only going to have like this apprehension when you're almost fully extended with the elbow.
So in that scenario, do you think the chair push-up test is a more sensitive test?
Yes, definitely.
So
by
you
far.
feel like that is a
yes. That is why I do both tests at the office setting.
And Michelle, in the literature, if you look, there has been, for example, I think one of the more common scenarios is to go for a reconstruction, right?
Yes,
People,
yes.
most of the time, they miss the acute stage, and invariably you identify those subset of patients in the reconstruction group. And
That's
the
right.
literature, there's been a description like docking technique versus onlay reconstruction. So can you explain, because we have a lot of readers from, viewers from different parts of the world, can you explain what has been that this docking concept. I think you mentioned in the presentation as well, the docking
Yes,
and onlay.
the docking concept includes doing tunnels, just trying to recreate the LUCL origin with the graft using bone tunnels both in the humeral side and also on the ulnar side. On paper, it's very easy to do because you have to do 3 tunnels on the humeral side and only 2 tunnels on the ulnar side, and then you're only going to pass the graft through these tunnels, and you don't need any device to fix your graft. But in real life, it's very difficult to calculate the direction of the tunnels. Once you do the tunnels, it is also very difficult to pass the graft through them. And finally, it's especially with the follow-up, I have found in the patients that I did the docking procedures, I have found some tunnel widening. And in those cases, I had to do a revision. And a revision in those cases is very difficult because you have bone loss. So sometimes you have to do a 2-stage revision. The first stage trying to take all what you did in the previous surgery, bone graft, the humeral and ulnar sites, and then in a second stage come and do the reconstruction.
So essentially, in the onlay technique, you're just putting a graft on the posterolateral part of the humeral epicondyle and connecting to the supinator crest on the ulna, right? So you just need a single
Yes,
lip.
that's
And
right.
what do you
Yes.
think the minimal diameter should be? For example, in the ACL, we say, okay, you need to have at least 8 mm, right? For example,
Yes.
for the elbow, I'm sure there's going to be some value on it.
That is also something that is very debated on the literature because many authors describe that with palmaris longus will be more than enough. And we know that it is not as thick as a hamstring. But in my patients, I think especially in very chronic cases, I will go for at least a 5 mm diameter graft. And in those cases, that graft will only be reached with a gracilis. And that is why I use a gracilis for these cases.
And while tightening, the final tightening procedure, what is the position of the limb? In what supination, what flexion?
You have to place the forearm with full pronation, 30 degrees of flexion, and applying some valgus force. So you can have a very congruent radiocapillary joint, and just having a tension at the graft will be more than enough if you place your limb in that position.
Michelle, just one last question. Michelle, sometimes we use the extensor indicis proprius, right? Sometimes it's an expendable tendon, right? You have 2 tendons there. So do you think that is a good source because the elbow close, the hand is quite close, right?
To be honest, I don't have any experience with that graft. I'm not. I have never taken that. I have never harvested that graft. So in my particular case, I will not feel comfortable using it. Although although surgeons that also have some hand surgery training probably will use it with very in a very safely manner. Definitely.
Thank you, Michelle. I think that's all the questions that we have for the session. Thank you for yet another fantastic talk and really
Thank
look
you very
forward
much.
to more in future.
Definitely. Take care.
Bye-bye.
And thank you for the invitation. Bye-bye.